think in the interest, we will move on to the next talk of Dr. SAMAR BASAK, who would be talking to us on pearls in the management of hydrops in corneal ectasias.
Thank you, Dr. Vanati, for having me here and include me in your power pack capsule of practice pattern. And I do not have any financial interest to disclose. And you know that it is not an uncommon complication of corneal ectatic disorders, especially the keratoconus, and we see also in PMD and rarely in post-lex cases. It is the sudden onset of corneal edema due to break in the DM, and common presentation are sudden impaired vision, eye pain, and eye appearing white. So risk factors are there like atopy, eye rubbing, mentally challenged patient, Down syndrome, and maybe anatomically weak corneas. So the mechanism is acute break in the DM endothelium level and influx of aqueous into the stroma and corneal edema, and disruption of posterior stroma and formation of fluid clefts in the stroma. So clinical examination is very important before managing these cases. Like you may find out fluid cleft in between the edema, and DM break might be visible in certain cases, especially with dilated pupil and retroillumination. Sedal test may be positive, it may be false positive, or actual perforation might have seen 3-4 cases. Actual perforation happens in particularly with PMD cases, and you may elicit sedal positivity. Always check the other eye for amount of ectasia is there or not. So the perforation, as I said, that sometimes that spongy stoma, they leaks and it may mimic perforation, so you have to be very careful whether it is a real perforation or false perforation in hydrops. Investigation, anterior segment AIOC2022, very important to find out the fluid cleft, DM break, scarring, of course, in late cases of presentation. UBM may have similar finding of AIOC2022, the imaging, oculizer imaging of the other eye if you get time, and people have done theoretical in vivo confocal microscopy. The treatment, medical management, if you consider that how the natural cause healing occur in 2 stages, reattachment of DM and endothelial migration. So many people actually suggest that medical management and the spontaneous resolution may occur after 8 to 12 weeks, but there is no defined clinical standardized therapy, so we give anti-glaucoma medication, hypertonic saline, steroid drops, cycloplegia, and lubricants. The outcome of conservative measurement at actual scarring, central or off-axis neovascularization is there, and off-axis scar may be improved vision due to flattening, and we have seen a lot of such cases, and improved contact lens fitting. But central scar, of course, need eventual DALC or PK. But the surgical management of acute hydrops is, there are many described, like fluid drainage only, intracameral C3F8 or SF6, compression suture, combination of all above 3 procedure, DALC, PK, or even the EK has been described. There are other rare management has been described like TPK, thermokeratoplasty with or without combined procedure, and publication mostly from China with encouraging results, and intracameral platelet-rich plasma injection that has been also described from Europe. The gas tamponade is basically important. Internal tamponade actually brings the DM break closer to stroma, so isoexpansile gas, longer tamponade, supine position, but there is no change in final outcome in terms of vision and need for subsequent keratoplasty. And compression suture is extremely important from externally. It brings the DM closer to the edematous stroma, works better with interstromal clips. Overlay suture or full thickness suture people have also tried. It should be perpendicular to DM break and combination with gas tamponade. So venting incision is also described, and probably if you have intraoperative OCT, you can see it, or if you have preoperative photograph, you can actually select the site where you could do a venting incision. Like in this case, you see that venting incision, and the surgeon is doing venting incision through the with a 30 gauge needle, and you see the gush of fluid has come out. And you can see from the other side, he is also trying to, so fluid has come out. So now you can see the break very well after that venting. So this is very important, and you can put the suture perpendicular this DM tear. So combined procedure with intracameral gas, good outcome, safety and efficacy of the procedure has been reported by multiple publications globally. And I'm sharing a case. This is done by another surgeon. You see that 39 years old lady with sudden DV for 3 days, and you see this is the AIOCT picture. You see that there is huge fluid cleft, and this is the amount of corneal edema, and surgeon is trying to do first venting incision. You see that similar kind of venting incision is going on, and then another to give little air before putting the compression suture, so give horizontal mattress kind of suture along the perpendicular to the DM tear. So basically externally you fix it. So you can give also radial incision in some of the situation depending upon your tear. So at the end of the procedure, you give little fluid also to check that pressure, then put a BCL, and this is day 7, clear cornea. People kept dilated. This is after 1 month. You see the vertical DM tear. So this is a good technique, and this is the ultimate AIOCT outcome. You see that only little DM scar over that area. So this method works well, and the complications are there: uvulate Jabalia syndrome, pupillary block glaucoma, and complicated cataract. But recently, Sunita and from LVPI, they have described a partial gas field with 80%, instead of 80% gas field, to avoid gas-related complication and quick and fast edema resolution. Last Saturday, we did this surgery. This is the pre-operative. Photo was taken after 2 hours, and post-op photo after 5 years. You see the clearance of this partial airfield, like 40 or 50% airfield. This is working, and you do not have to worry about pupillary block or other uvulate Jabalia syndrome. So other PK and DALK, I think the Rajesh will be talking about it, but manual layer by layer technique will be better. And then the people has tried endothelial keratoplasty, also DMAC patch graft or dissect patch graft from inside and air tamponade. So in summary, acute HYDROPS in keratoconus or other ectasia is not so uncommon. Good slit lamp evaluation and AIOCT may give clue about the size and location of DM tear. Compression suture with partial air-filled intracameral gas and or fluid drainage is the best option. Full or 80% more gas fill have more complication we have seen in our practice. Outcomes are mostly good with further better contact lens fitting later on. Manual DALK or PK with central scarring is the later option. Other treatment may have, you can try in selective cases. Thank you very much for your patience hearing.
Thank you very much, Dr. Basak here. I do agree that compression sutures do result in very rapid resolution. May I ask you, is there any different technique by the way you place your compression sutures?
We go from externally, we don't go full thickness, so only horizontal, and it should be perpendicular to your, like fusiform, usually fusiform kind of DMTR. So your suture should be perpendicular that, and you must tighten it according to your, I mean, put a little bit gash or air so you can tighten it in very nicely. And if you have scope for fluid drainage, that is wonderful because corneal thickness reduced instantly and you could have better tightness of the suture. And you remove the suture after 7 days, 12 days, 15 days, depending upon the clarity of the graft, I mean cornea, and also amount of gas inside.
So those are very useful tips there, that you place the suture perpendicular, try to identify the cleft.
These are all 10-0. I have never tried, but I have tried 9-0. 8-0 monofilament nylon is very difficult to get in the market, but 9-0 I have tried with thicker, I mean, edema, very thick edema. You cannot see with ASOCT, you cannot cut the posterior.
Yes.
That time you may use the 9-0 because you have a better tightness. 9-0 monofilament, but 8-0 I have never tried.
Because 8-0 Vicryl we use a lot of
Vicryl?
times in- Yeah, Vicryl.
Oh, I have never.
You're only using it for a week. So
Yes.
if you
Yes,
want
yes.
Vicryl, it's, you can get better
Gives you a
compression
better
of the cornea.
tensile
Yeah.
strength and yes, and
Vicryl,
approximation.
okay.
And
So
you
that
used
way
to-
virgin silk can also be used.
Can be used, but that may accumulate a lot because it's braided. Sometimes you may get a lot of
Okay.
discharge or mucus sticking to
The
that suture
8-0
compared to
Vicryl
a-
also polyfilament, polyfilament, not
But I'm
mono.
just thinking in terms of, because 10-0 sutures are sometimes very difficult to get the kind
Break.
of tension,
So
they breaks. So
nine-
if you use 8-0 Vicryl and you're using it only for a week, if you were keeping it for a month or
Yes.
so, then maybe yes, you keep
Yes.
nylon.
And-
But otherwise, Vicryl
9-0 we have used in
Rajesh,
thicker.
maybe 10-O Vicryl, maybe I will prefer 10-O Vicryl because 8-O Vicryl, the needle spatulated a little bit, putting it through the
Yes,
cornea,
yes.
maybe looking.
But 10 of Vicryl, we have used it, but it is so, I mean, you have to be very careful. The tension, it easily breaks.
Yeah.
That is,
I
and it
do
is
prefer
expensive
9-O
also.
nylon.
Very much
But of
I
course
expensive.
we
use
have
the
to go
8-0
for
for traction suture for glaucoma surgery, so it's
Yeah.
not that difficult
Yes.
to take a bite. So I think
Yes.
depends on what you're comfortable.
Absolutely.
Thank you,
The
thank
key
you.
point is, remember, there are interstromal sutures here. Identify the cleft, go perpendicular to it, place a BCL on it always. Helps in rapid resolution. You do not need to use gas intracamerally then. Air works fantastically and does away with the disadvantage of a pupillary block glaucoma in these